Hello and welcome to the fifth seminar of Public Health 1, which is about evidence-based medicine. This seminar will provide you with an overview of EBM and the practical aspects of applying EBM in daily life. Yes, I know that most of you are now familiar with what is evidence-based medicine from previous seminars and also from the lecture that was dedicated for this style of medical practice. But today we will talk more about the practicalities of these styles. So at the beginning, I would like you to understand how much it is important for today's doctors and definitely for tomorrow's doctors to learn and practice EBM. And the answer for this question, I will cite it from Professor Paul Glasziou in his article that was published in the British Medical Journal a few years ago. According to Professor Glasziou, in medicine, we are continually making decisions. And if medicine is to be a science or learning profession, we need to think critically about how and why we are making these decisions. So the thing that you need to learn about your future practice or future profession is that you're gonna make decisions every hour or even every few minutes. And this is because in each and every case you encounter, you have to make decisions regarding their diagnosis, regarding their further examinations if it's needed to reach final diagnosis, and definitely for their treatments plans, and also for their follow-up outcomes. For all these aspects of medical practice, you need to have the capacity to make the right decision in the right moment. And that's why we need to think of the mechanism that you will develop or you will use in order to make these decisions. It doesn't matter what the decision will be at the end, because this can vary significantly, as you can imagine, according to the cases or according to the individual situations. But at the end of the day, you need to have a rigorous methodology or rigorous intellectual framework to make these decisions. And this is exactly what is the evidence-based medicine is for. It doesn't matter if you see your profession as a scientific profession, which is deeply rooted in science, or if it's a profession that is based on gaining experience through like clinical practice. At the end of the day, you have to make these decisions, and these decisions need to be made in a good way or in an effective way, because this is how we can help our patients. So, in a nutshell, if you would like to imagine doctors who cannot read scientific articles from journals, as you can see here, like Lancet or the BMJ or JAMA or other reputable journals. This is the same doctor who cannot measure the blood pressure using the stethoscope. So you can imagine how much it is important for you in the future to be able to read and critically appraise and critically evaluate the scientific evidence you find in medical journals, because this will definitely shape your decision regarding your patient's care. Then the definition of evidence-based medicine that most glossaries agree upon is that it's the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. So there are three key words I would like you to think about here. First is that evidence-based medicine uses the current best evidence. This is the scientific evidence that is driven from the medical literature. And the second element is that this evidence is used to inform the clinical decision. And the clinical decision is taken by the clinical practitioners or the doctors who have definitely some sort of experience. And these decisions are made in order to help the patients or the recipients of the medical care, who should be respected in order to gain the most benefit of these interventions. So these are exactly the three elements of evidence-based medicine, because I can imagine that some of you or many people in general also think that evidence-based medicine is about applying scientific evidence for patients' care without any respect for doctors' opinions or patients' values. This is not the case. We need to have a harmony between the three elements in order to achieve the best care for our patients. And this is exactly the elements of the EBM. So if you would like to, again, imagine the principles of EBM, as I said earlier, we need to integrate clinical experience, patient values, and the best available scientific evidence. And the interplay between these three elements is exactly the EBM. Also, EBM is not a dogmatic book, because as you can see, there are elements like the clinical experience of the doctor and the patient's values that are extremely individualistic, and that's why the scientific evidence on its own cannot be blindly and exclusively applied without respect to these other elements. And that's why there should be some sort of resilience of how we apply EBM, because as I said, we need to respect our patients and also our doctors' values, sorry, our doctors' experience. Tomorrow's doctors, or you, hopefully, in the future, have different tasks in EBM. First, you need to use the clinical practice guidelines and evidence summaries in your clinical practice, because these are the sources of information that you should read and you should use in helping your patients. Also, you need to support the movement itself, or the workflow that generates these clinical practice guidelines. These are the systematic reviews and evidence-based guidelines that need to be continuously updated, and you should dedicate some time. I mean, here, when I say you should, this is definitely a moral obligation that you should think of, because we need to keep these sources as much updated and as much useful for other doctors and other colleagues. Also, whenever it's possible for you to help in recruiting patients for clinical trials, this is also another moral duty that you should not forget, because this will definitely help our systematic reviews that will be published later, and updating the practice guidelines according to the most realistic information we can learn from our practices in the moment. Okay, so these are the three tasks that we can simply say here about what doctors need to do for supporting the EBM movement and to play a significant role in it. And now let's see the EBM approach itself, like how it is really applied in like real world. As you remember, we had the 5A approach, or the 5 steps, which start with asking a clinical question, then acquiring scientific evidence or the best evidence that should answer this question, and then we need to appraise and we need to evaluate this evidence before using it, and then we need to apply this evidence, and finally we need to analyze and keep evaluating this evidence. So this is kind of a circle. We first start a question, then after we start asking this question, we need to find the answer for this question from the literature, and then after we find the answer, we need to evaluate and appraise it and critically think about these answers or these papers that we have read, and then we need to apply this evidence and improve the patient's care as much as we can, and then evaluate these changes that we have implemented and keep the cycle rolling. All right, so before we go to the workflow of evidence-based medicine, I would like you to just think with me for a little bit about the medical evidence itself, or the nature of evidence. Clinicians need to be able to search for the answers that is needed for their questions about their patient's care. And this is usually coming from, as I said, clinical practice guidelines or evidence summaries. And the clinical practice guidelines are not supposed to be a cookbook, as I said about evidence-based medicine, which means that they are just guidelines that should help you to think about what you should do. They are not rules. They are not obligations for you to be followed. You can ignore them at all if you don't want to do it, but you are also strongly recommended to use them, because this can help you also legally to avoid any legal asking in the future if something went wrong. High quality guidelines represent the wide application of research evidence to the realities of clinical care, because as you will see here in this table, these are the standards of the trustworthy clinical practice guidelines, as we call them. I will not be able to explain all this in detail because this will take a little bit of time, and I'm sure that you can understand it on your own, but I would like you to think of one of these standards, which is the systematic review. So systematic review is the building stone of clinical practice guidelines. So practice guidelines should be based on several systematic reviews that should inform the recommendations that are implemented in the practice guidelines. And so we need to do as much as possible of systematic reviews to make enough evidence or enough answers for the clinical practice recommendations. If you remember, in the third seminar, we talked about the hierarchy of evidence, and systematic reviews and meta-analysis was the highest level of evidence, and that's why these type of studies are used directly to shape the clinical practice guidelines and evidence summaries that doctors use to help their patients or make decisions for their patients. Um, Also, remember that systematic reviews, as we said in the lecture, are rigorous reviews, which mean that they are done in very rigorous and robust way that will make them transparent and replicable in the future. So if a researcher followed the steps of a previous researcher who did a previous systematic review, he or she should get the same results as the previous researcher, because all the information about how the systematic review was conducted should be published publicly and should be repeatable, which means that if they are repeated, they should give the same results. The workflow of systematic reviews can be summarized using the Prisma flow charts or the Prisma flow diagrams. The first stage of any systematic review, as you can see in this graph, which is called the Prisma graph, is identification of studies. So after you ask the questions and after you search for the answer of this question, you get some number of studies. Then this number of studies need to be screened initially, because not all of them will be useful, of course, and those who are not relevant should be excluded, and those who are repeated studies or like duplicate studies need also to be removed. And then you need to assess them for their eligibility to answer your clinical question, and once you see that those studies are really eligible to answer the question, you should start to critically appraise them, and then after critical appraisal you can make a summary of the studies or you can synthesize the evidence. So in nutshell, if you have in this diagram, for example, 12 studies to be included in the systematic review and the meta-analysis, the quality of the evidence that will come out of the systematic review will be definitely dependent on the quality of those individual 12 studies. Because if those 12 studies or if those so those 12 individual studies were done properly or were done with high standards, then their outcomes will be of high quality, and so the overall evidence from these systematic reviews that is based on these 12 studies will be of high quality as well, and definitely vice versa. If the individual studies were not good enough, then the evidence that come from them will not be good, and then the overall evidence from the systematic review will not be also good or useful. Okay, so let's start with the steps of evidence-based medicine and take them one by one, because those steps, as you will see later, will resonate too much with the steps of the systematic review workflow. So first of all, we need to generate a clinical question. This was letter A of the EBM approach, asking a question. And for some of you who did not attend the lecture, I will just give a quick recap for what we said in the lecture about clinical questions. So clinical questions is the first step in EBM, because this skill, however, it's important, you will realize that not all medical students and not all doctors even are able to make it or to make these clinical questions. Because in the beginning of your education and the beginning of your career, you will be only able to make background questions. So in general, you have very like vague idea or very brief idea or a very preliminary idea about diseases and medicines, and that's why your questions tend to be very general. Like for example, what are the symptoms of COVID-19? What are the symptoms of seasonal influenza? How can we differentiate them? So all these kind of questions are called background questions because they are very general. They are not really focused on certain problem to be resolved. But then later on, once you gain more knowledge, as you can see, once you move from novice to expert level, your questions will become more sharpened and will become more clear and more focused. And those are called the foreground questions. And the foreground questions will be the questions that will inform the establishment of clinical questions. So clinical questions are an advanced format of foreground questions. So not all foreground questions, of course, are clinical questions, but those dissected questions of foreground questions can be considered as a clinical question. So the clinical question is a dissected foreground question that is, as I say, dissected into into 4 elements. For example, according to the PICO element, it's the patient, intervention, comparison, and outcome. So again, background question will lead to foreground question later on once you gain experience, and this foreground question later will lead to the clinical questions that we need you to learn how to establish. I will give you an example now to make you understand how this process takes place. First, a background question can be, for example, what is hypertension and how is it managed in adults? So this is a typical question for early year medical students, like first year or second year or even later years. So this is a very general question. It's crude. It doesn't really look for certain solution of certain problem. That's why this will lead to foundational knowledge or gaining as much knowledge as possible and in this stage of your education. Later on, once you gain more information and more knowledge in your school, you will be able to establish a more focused question, which is called the foreground question. And for example, in this case, this will be the efficacy of thiazide diuretics compared to beta blockers in lowering blood pressure in adults with hypertension. So now you are able to think about medicines that can resolve this disease, and you are thinking about how to choose between them because you are confused which one is better for your patients or for the patients that you will see in your future career. And so these questions, which are the foreground questions, are more specific and, as I said, can lead to practical solutions. Then the clinical question itself will dissect these foreground questions in its core elements. And the core elements of the foreground question are the patient element, the intervention element, the comparison, and outcome. So patient in this case was adults with hypertension, because these are the people that we are trying to help. Then the intervention that we try to see its effectiveness or its like clinical benefit is the thiazide diuretics. And then the compare the treatment, because this is very important. How can you tell if the diuretics are important, or sorry, are useful or not if you are not comparing them to another treatment? That's why we have always to have a comparison group in order to see if the new treatment or if the treatment that we are looking at is useful or not. So the comparison in this case was beta blockers, and the outcome is definitely reduction in systolic or diastolic blood pressure. So if you would like to write the clinical question eventually, this will be the format of the clinical question in adults diagnosed with hypertension or in hypertensive adults patients. How effective are the thiazide diuretics compared to beta blockers in reducing systolic and diastolic blood pressure? So as you can see, the clinical question need to reflect all the 4 elements, and they should reflect them clearly in the question. So all the 4 elements need to be clearly integrated in the question in order to call this question as a clinical question. Of course, clinical questions can vary in their types according to the context or the problem that you try to resolve. So usually we use the PICO element because this is the element of effectiveness questions. So if you are trying to find the effectiveness of certain medicines or surgeries or other interventions, then you're gonna use the PICO elements because you have population, intervention, a comparison intervention or comparison treatment, and then the outcome. If you are looking for diagnostic accuracy of some tests, you should use another framework, which is called the paired framework. This is the population, which are the people with certain disease. So this is the patient population, then the index test and reference test. And I'm sure that you remember what is the index test, which is a new test, and reference test, which is old test or the gold standard test, and the diagnosis, which is the outcome of measurement, which is disease, as you can imagine. And etiology and risk factor, those are the questions that try to find out what is the reason for the disease that we are seeing. So if you have an increased number of cases of certain disease or certain infection, then you should look for what could be the reason behind this. And these are the studies that use the PEO framework. So PEO framework has population, exposure, and outcome. Okay, so exposure could be the potential risk factors or the potential etiologies that we test for, and we can see if they are associated with the outcomes or not. Then Prevalence and incidence. If you try to measure prevalence and incidence of some disease in certain communities during a certain period of time, then you're going to use the Cuckoo-Pop framework. So the Cuckoo-Pop framework has the elements of condition, which is the first CO. Then the second CO refers to context, where this condition is found or the patients are living. Either they are recruited from community setting or clinical setting like hospitals. It doesn't matter. This is a context where they are living, and we need to define specifically where we are looking for this disease, and the population, which is the target patients or the target humans who have this condition. Then the qualitative evidence, which is the evidence that tries to dig for in-depth information about the problems, like the experiences of patients after surgeries or during the rehabilitation stage. So all these experiences can be examined like ideally using qualitative evidence, and the qualitative evidence questions are answered using the PICO framework, sorry, the other PICO framework, which is population, phenomenon of interest, and context. All right, so these are the types of clinical questions that are different based on the context and the purpose of the question itself. Let's say this exercise to learn how we make clinical questions. Jeff is a 40-year-old man who asks you for advice on ways of resolving his depression without using medication. So he's probably not very interested to take drugs or medicines. He's particularly interested in whether he would gain any benefits to his mental health from cognitive behavioral therapy. So he prefers to get some psychological support or some psychological treatment rather than pharmacologic intervention. So let's see what are the elements here. First of all, this is a clinical effectiveness question because we are comparing different treatments like the pharmacologic or the psychologic intervention. And the first element, which is the P or population element, is male patients with depression, or you can say patients with depression. It doesn't matter. And then the intervention that the patient is interested in receiving is the CBT or the cognitive behavioral therapy, which is the psychological intervention. On the other hand, the comparison should be the pharmacologic, which is the antidepressants, and the outcome should reduction in the depression level or the depressive symptoms. So the question that we can make in this case would be, how does the use of CBT compared to medications help in treating depression in middle-aged men? So this is simply the clinical question that can be made for this case. Another case is from Sarah, who has family history of breast cancer. That's why she asking you for advice whether to undertake a yearly mammogram instead of every 3 years to be assured regarding her risk of developing breast cancer. So this is not an effectiveness question because we are not looking for treatments. There is no treatments here. Like this is mammogram either with 1-year frequency or 3-year frequency. So this is more as diagnostic accuracy question. That's why we're gonna use the PERD framework. The PERD framework starts with population, which is middle-aged females. You can also add that these middle-aged females could have family history with disease. And then the index test or the I element will be the annual mammogram or every year mammogram, and then the reference test or the conventional or the gold standard test for mammograms is the triennial mammogram, which is every 3 years, and then the diagnosis will be the breast cancer that we are looking for. It's either there or not there, and the question will be in this case will be, is a yearly mammogram more accurate in detecting breast cancer compared with a mammogram every 3 years in women under age 50? Okay, so these are the elements of the PERD question. First, you need to read the case carefully and think about it, whether it's a case for treatment or diagnosis or diagnostic method, and then you're gonna look for the elements or extract the elements from the case, which will be according to the framework that you get. After you make your question, you should think about the evidence or the answer for this question and where to find it. You can find answers in online sources like PubMed, Cochrane Library, Web of Science, and you can still find answers in social media platforms or Google or even the free encyclopedia, which is Wikipedia. I will cut it short for you and tell you that the first group is the one that we use, not the second one. And the criteria for why we choose the first one is that we need an evidence that is attainable, which means that it should be accessible for as many people as possible, and especially doctors. This evidence should also be obtained from research, and it has to be updated and timely, of high quality, applicable to individual patients, and appropriately the best. So all these criteria can be only applicable on the evidence that we get from biomedical databases like PubMed and Cochrane Library and others. The United States National Library of Medicine provides a good framework for dividing these sources or classifying these scientific sources. This model is called the COSI model, or the Core Standard Ideal, because there are three groups of the databases that you can use. The first group is called the core group, the second is the standard, and the third is the ideal. The core group is usually the group of databases that are quicker, which means that they are easily accessible for many doctors, and they are all free of charge. I mean, you don't need to make subscriptions even to log in. The evidence that you are finding there is usually more precise because these databases include only good journals that publish good quality or high quality research, and that's why the results that you can find in core sources is usually the best results. And then if you'd like to make your search more inclusive, and if you'd like to include more resources, then you're gonna go for the second group of resources or the second group of databases, which are called the standard databases. So the standard search will include both the core plus additional sources, which are more gray literature, which means that these journals are not seen as very good journals. This doesn't mean that they are bad journals, but this means that they are less reputable. And in order not to be scared about the word gray literature or not reputable journals, any journal that is not published in English, I mean English language, is high likely to be a gray literature because these databases that we use, like PubMed and others, are English sources. That's why the journals that are published exclusively in other languages like Chinese, Spanish, Portuguese, Russian, Arabic, and others, all these journals will not be indexed normally in PubMed except if they are translated into English or if they have translated versions. That's why we should not consider these journals as bad journals or evil journals, because they can still have good evidence, but this will definitely take more time and more effort from our side. That's why we keep this for the second stage if you really want to have more information. And yeah, of course, the results here might not be as great as the core sources. But if you would like to make your search as an ideal search, you need to include more and more studies. And these more and more studies will not come only from articles, I mean, in medical journals, but you can come also from conference proceedings, which are the abstracts that are presented in medical and scientific conferences, the clinical trial registrations. So if there is an ongoing clinical trial that is not yet published, you can consult with the researchers and try to ask them for their preliminary results and think about it and decide if you're going to use it or if you're going to use them to make your decision or not. So this is the three groups, or these are the three groups of sources. The core is usually what you need to learn how to use. The standard and ideal are a little bit for more advanced researchers. So not all medical doctors need to use the standard and ideal sources, but definitely for all doctors, you should learn the core sources and how to use them. So the most commonly used core source is called PubMed, and PubMed is a search engine. It's not a database because it's based on a database which is called Medline. Anyway, PubMed is a search engine that is owned and operated by the National Library of Medicine of the US. This is how it looks like if you go to the website, the official website of PubMed. It has more than today 36 million citations. You can imagine how many articles are stored there. And they are all driven mainly from the Medline database, which is the database of the National Library of Medicine. So the National Library of Medicine has a database which is called Medline, and this Medline database can be accessed freely without any charge, without any subscription, using the PubMed search engine. The PubMed search engine and Medline covers topics or cover journals that are operating in the topics of biomedicine and health, and all specialties of medicine, as you can imagine, are covered in PubMed. The database is updated on daily basis, and this means that you can expect new articles to be added for the topics that you are searching in. So if you have a specific focus on certain disease or certain problem, you can make an alert for getting updates about the articles that are published or indexed every day in this topic. So you will be updated about what's in the field or what's happening in the field that you are interested in. Here I will share with you some features about the PubMed as a website and as a search engine, because as I said earlier, it's based on the Medline database. So if you go to pubmed.ncpi.nlm.nih.gov, you will find this and you can start search from this point. There is a concept in PubMed which is called the mesh term. So mesh is the medical subject headings, and this is important to be used if you would like to make your search more focused, because you can use these keywords. I mean, mesh are keyword in like simple terms in order to find all the articles that are related to this mesh term or this certain keyword. So this is how you can search in mesh terms, and this website that I'm sharing with you here is the website where you can search for these mesh terms, not the articles that are associated with these mesh terms. So first you're gonna search for the keywords, which is the mesh term, and then you can use this mesh term in the original website of PubMed to search for the articles that are associated with this mesh term. So if you, for example, think about certain disease and you don't know all the other keywords or all the other names that can be used to describe this disease, then mesh is a good source to learn about it. So for example, in our article, this was one of our articles, you can see that there was a list of mesh terms that the PubMed and the like database of Medline had suggested for our article to be called with. So we didn't use these keywords in our article, of course. We definitely use these words in parts of the article, but we didn't specifically decided that these are the mesh terms or these are the keywords that we want for our article. But then once the article is indexed or was indexed in PubMed, PubMed decided to add these mesh terms to the article. So later on, for other researchers, if they want to search about studies that included adult population with adverse reactions about COVID-19 vaccines, then our article can be easily found for these kind of searches. So this is why mesh terms are important to be used, because they will like rapidly make you accessing the studies that are related to the topics that you are searching for. So you will exclude the irrelevant studies, for example. Also, you can use filters and tools in the search engine web page. So for example, when you search for COVID-19, you're gonna find almost 395, which is roughly 400,000 studies. And of course, it will not be easy to read all of them. So maybe you are interested only in clinical trials. Maybe you are only interested in meta-analysis or review articles. Maybe you are only interested in the studies that were published last year or in the last 2 years. So all these filters and other filters that you can find in PubMed webpage can be used to narrow down, narrowing or widening your search and make it more consistent with what you are interested in learning. Other feature of PubMed is the NCPI account. So if you are using PubMed for the first time, you cannot log in directly. You need to sign up first, and you can even sign up using your university account. So you don't need to have like special account in PubMed. You can still use your Muni account or your Massachusetts University account to log into PubMed. How this is possible? First, go to login, then more login options, and search for Massachusetts University name, and then you're gonna log in through your UCHU account or your university identifier account. This is a platform that you should see after you log into your account or after you establish your account, and as you can see, it has several features or has several benefits. First, you can save your search operations, so you can revisit them later on if you would like to see. You can make search alerts, and this is what I said at the beginning. So if you are interested in certain disease or certain medicine and you would like to be updated of the new studies or the new articles that are published about it every day or every week or whatever other frequency, then you can get alerts by your email, or sorry, to your email about the new articles in this topic. And you can customize display settings for the studies that you are searching for in general in PubMed. Also, other features in PubMed is that you can access the full text of the article. Remember that PubMed is a search engine, it's not a database. So you should not expect to find the article itself in PubMed. However, you can find the title of the article or the information about the article that you can use to search for the article in its journal website. So each journal should have a website, and you should search for these articles in the website. But PubMed has a good feature, which is link out. So link out in any article is this button that will directly send you to the journal website and specifically to the article web page. So you don't need to search in the journal or to search for the journal website first and then for the article within the journal website. You can just directly go to the website or the web page of the article in the website of the journal. Also, the PubMed Central is another feature that can make you access the full text of the article, because PubMed has, and NCBI specifically, the NLM, has agreements with some publishers. That's why the full articles of some journals, of some publishers, are stored in PubMed. Because they are open access, and based on these agreements you can find them easily from PubMed Central. So if you find this button, which is called BMC or PubMed Central, it means that the full text of this article is stored in PubMed and you can go and read it freely without any costs or without any charges. Okay, so these were probably that I wanted to share with you about PubMed as a search engine. Now let's see how we build search strategies to find evidence. But before we make the strategies, we need to establish the question first. So the question, according to the BICO framework, has to be made, and then we will learn what are the elements we should look for, what is the population, what is the intervention, what is the comparison, what is the outcome, because this can bring the keywords that we will use for the search strategy. And one of the important components of search strategies in PubMed is the Boolean operators. So Boolean operators are the operators that are logically connecting the keywords in the search strategy. Imagine that you are interested in learning the effectiveness of adjuvant chemotherapy in breast cancer women. So population is breast cancer, adjuvant chemotherapy is the intervention. And of course, not all breast cancer studies or not all the articles in PubMed that studied breast cancer had used chemotherapy, and not all the studies that used chemotherapy used it only for breast cancer. Maybe they used it for other type of cancer. So you need to look only for the studies that specifically looked for breast cancer patients and at the same time treated them using chemotherapy. That's why you want to look for the intersection between breast cancer as a concept and adjuvant chemotherapy as another concept, and this will be only possible with connecting them using the AND operator. Okay, so the AND operator will combine the will look for the studies that are mutual between the first and the second concept. If you would like to connect two concepts with the operator OR, it means that you want to include all possible studies from these two concepts. So if you would like to have all the studies that are about breast cancer and all the studies that are about chemotherapy without discrimination and without looking for specifically for those who used chemotherapy for breast cancer patients, then in this case you're going to use the operator OR, because OR will cover all the studies for both concepts without any discrimination. Finally, if you're gonna use the operator NOT, this means that you want to exclude one of the two concepts and exclude even the mutual studies that are associated with this concept. So if you would like to look for the studies that focus on breast cancer patients that were not even treated with adjuvant chemotherapy, then you're going to use NOT, because maybe you want only to look for radiotherapy or other treatments and you don't want to waste your time by looking at the patients that were treated with chemotherapy. So in this case, you will look for only breast cancer patients without even chemotherapy. Okay. Okay, so this is the not operator and how it helped us in making the strategy. Also, another feature of the search strategies in PubMed is the asterisk, which is this star. If you think about a keyword that could have variations at the end of it, like for example, vaccine, vaccines, vaccination, these all have the same root, which is vaccine. And then, if you would like to save time and not be afraid that you may miss the plural or the singular formats, then you can use this asterisk. So as you can see, when I applied asterisk after the vaccine, the VACCIN, the studies that came from the first page, also other pages, included vaccination, vaccines, and even the singular format of vaccine. Okay, this is the rule of using asterisk for tourniquetation. Also, if you would like to search for a disease that has long name, for example, acute myocardial infarction, or human immunodeficiency virus, or severe acute respiratory syndrome, SARS. So all these phrases describe one disease, but you have to be careful because these are different words, and the search engine may not understand that this is a connected word or this is one disease or one name. That's why you're going to use the quotation marks. So if you use quotation mark, the the search engine will understand that you are searching for this phrase specifically. So you cannot find the studies that have these words like separated or not connected all together. You will only find the studies that connected these words as one sentence. Okay, then you can use mesh terms, as I said earlier, to find articles that are connected to certain subject, regardless of the terms that were used by the author. So as I told you earlier, in my study or in my case, I didn't use the keyword adult. But of course, the patients that I described in my study or I examined were all adults. That's why the mesh term that was connected to it was adult, even though as a researcher I didn't say it. So this is good because as a user of PubMed, you may not find the studies saying specifically in their keyword list that the patients were adults, but the mesh term will help you to identify these studies that will save you a great amount of time, of course. And as we said earlier, you can use filters and limits to narrow down your work, and you can also apply these filters and limits within the search strategy. So the search strategy can include Boolean operators, can include asterisks, quotation marks, mesh terms, and filters to produce the studies or like bring the studies that are relevant for your question. So as an example here, we can think about COVID-19 patients as population, corticosteroids as intervention, using no corticosteroids or using no medications or having placebo, for example, as another control group. And the clinical improvement of COVID-19 patients should be the outcome that you are interested in. So if you think about this question, which elements you're going to use, maybe patients and intervention, and I will tell you why. Because if you think about the placebo, which is the control group, this is not easy to find keywords that describe no treatment or placebo. Yeah, you can use no treatment, you can use placebo, but this is kind of like endless mission because there are like endless number of words that can describe this. So it's better not to include it in order to avoid losing time and wasting time in this keyword. Also for the clinical improvement, if you are searching for clinical improvement in general without specific endpoints or without specific clinical criteria, then in this case it's a good idea to abandon using the outcome like as a parameter because it will not be easy to find the keywords that describe it precisely. So that's why we used the population and the intervention keywords. So in order to describe COVID-19 patients as a concept, you can use the word COVID-19 or SARS-CoV-2 or 2019 NCOV or coronavirus disease or severe acute respiratory syndrome. And as you can see, I have used the operator OR because I want to include all the studies that covered all these concepts all together. So I don't want to discriminate between them. I want to include all of them without even looking at the mutual or the intersecting studies or the replicating studies. I want to have everything. Okay, and I will apply the same concept for the second concept, which is the corticosteroids. So corticosteroids or corticoid or dexamethasone or cortisol, all these keywords are examples of corticosteroids, and I need to combine them using the operator OR. And then I will make a combination between these two concepts using the operator AND. But you have to be careful because you need to have brackets between brackets before and after the first concept, and brackets before and after the second concept, and then between these two concepts you can use the operator AND, because you want to have only the studies of COVID-19 patients that were treated with corticosteroids, not all COVID-19 patients. You need specifically those who were treated with corticosteroids. This study is, by the way, one of the famous Cochrane library reviews that were published in 2021 and further updated. And this is the search strategy that is used in real life. So I will just want you to show, to see how it looks like here. So these are the keywords of the first concept, which is the corticosteroid. As you can see, this is huge list of names of drugs of corticosteroids group. And then in the second part, we have the keywords related to COVID-19, SARS-CoV-2, and others. And then they used the operator AND to combine the keywords or these two concepts. And finally, they applied other filters related to the type of study or the title, abstract, or others. And finally, the search strategy was produced based on all these instructions that were given to the search engine. Okay, so this was the second step of evidence-based medicine, which is acquire, how to acquire the evidence. Now let's see, after acquiring the evidence and after having the studies that should inform your clinical decision, how you're gonna use them. First, you need to screen them, because as I said earlier, not all of them will be definitely relevant. Some of them could be just like irrelevant or just like distracting and wasting your time. That's why you need to have a streamlined approach to help you to exclude those who are not really, or which are not really useful. And the approach here that I'm talking about is the title abstract screening approach. So at the very beginning, if you have, let's say, 500 articles, you're gonna read only the title of these articles, because the title of the article can help you to decide whether this article is useful or not, or is relevant or not. Because maybe if you are searching for clinical trial and the title say that this is in vitro study or in vivo study, so or animal study, so this all mean that this study will not be a clinical trial that you need for your question, so you're going to exclude them just from reading the title. The same also for the abstract, because the abstract will include useful information about the study design, about the methods, about the results, about the conclusions in this study. So all these information in the abstract can help you to make a very quick decision about either inclusion or exclusion. And let's imagine that after you reviewed the title and abstract of these 500 articles and you decided to exclude 400 of them because they were definitely irrelevant based on what was written in the title and abstract, then you're going to move to the second step, which is the in-depth review, which will be for the whole article or for the full text of the article. So now you're going to read the full text of these 100 articles in order to decide which of them are useful or which are relevant for you. And maybe within this step or within the second step, you will find out that there are additional articles that need to be excluded from these 100. Maybe another 50 articles need to be excluded because they are not specifically on the question that you are looking for. Maybe the dosage of the medicine is not what you are looking for. Maybe the way of administration is not the same. And maybe the clinical outcomes that were recorded are not what you are really interested in. So for this, you can do another round of exclusion based on reading the full article, the full length of the article. Okay, so um, after you read all this and make all these decisions, you can start critically appraise the evidence. So critical appraisal is, as you can imagine, the judgment of this evidence based on its quality and its usefulness, because not all medical studies, not all clinical studies have the same quality, and that's why you need to employ your critical thinking skills and critical sense in each and everything that you read from scientific journals. Of course, there are good journals that inherently publish good articles, but this is not a trademark of quality of accepting the information in these articles. You need to still critically appraise it and read it with high level of criticism. Okay, so there are tools that we use for making these critical appraisal in systematic reviews and in evidence-based medicine. These tools are checklists which have certain questions, and you need to answer these questions based on certain explanations from the tool developers. And based on the answer that you will get from these questions or from these checklists, you can make an overall estimation for the quality of the study, whether it was of high quality or moderate quality or maybe low quality. Okay, and again, these checklists have signaling questions. Like for example, here in this GBI checklist, we have the first question about the sample representativeness. Was the sample that was used in this study representative for the target population or not? And you can say yes, no, or it's unclear, or even it's not applicable for this study. So once you answer all these 10 questions, you'll be able to make something like this. So this summary here that you see, which is the colored one, include different colors, and green color means low quality, sorry, low risk, low level of risk. Yellow means moderate level of risk. Uh, uh, Red means high level of risk. So the good studies are those who have like most green colors in all domains of potential bias, and the bad studies or the less like robust studies will be the ones that have more yellow and more red colors that indicate like increased risk of bias and low quality of the evidence, definitely. Okay, in this exercise that we will do at the classroom, I want you from now on just to check this website, which has a list of the critical appraisal tools that are used for different study designs, and download the checklist of case report, checklist of analytical cross-sectional studies, and the checklist of cohort studies. And I would like to gently ask you to just read the explanations for each checklist, just as a training for you. And in the seminar or during our classroom, we will apply these in real life. So I will have studies that you will evaluate based on this checklist. So it's a good idea for you from now on to just have a quick idea or quick overview for the components of these three checklists. The one for case report, the second one of analytical cross-section studies, and the third one for the cohort studies. All right, so after evaluating the evidence, after critically appraised, scientists and researchers do an evidence synthesis. They make summary for the evidence. The summary could be either qualitative or quantitative. So qualitative summary is, for example, thematic analysis. So here, uh, this is a process of reading texts and categorizing them according to certain themes. So you try to establish themes for the problem or the phenomena that you are examining, and you will be able to make this after you read as much as possible of articles to understand what are the areas or what are the categories within this phenomenon. Then the meta-ethnography is an advanced technique that is based on thematic analysis. So you do thematic analysis, but then you can later apply the meta-ethnography. And meta-ethnography has several techniques that involve mapping of the key themes, which is similar to the thematic analysis, identification and resolution and of any contradictions, building the general interpretation based on the data. So all these steps are additional steps to the thematic analysis that will make this type of research as meta-ethnography. Also, we can make quantitative synthesis, which is more commonly used in medical research. That's why we commonly say it as systematic review and meta-analysis. So the meta-analysis is the quantitative, formal epidemiological study design used to systematically assess the results of previous research to derive conclusions about the body of evidence. So the statistical analysis of results from systematic reviews is called simply meta-analysis. So this is a statistical analysis of the results from uh, systematic reviews. Meta-analyses are usually presented in the forest plots. So the forest plots that you see here is the graph that typically represents the results from meta-analysis, and it includes both the point estimate and the interval estimate of each of the clinical studies or each of the individual studies that were gathered and aggregated in the meta-analysis or in the systematic review. So each line that you see here, each red line I'm talking about, represents a certain study. The point or the box means the point estimate, and the line, which is the other red line around this box, is the interval estimate or the 95% confidence interval. And now let's see how we interpret forest plots, because this is a very important skill for you as a future medical doctor, because you're going to see forest plots everywhere in systematic reviews and meta-analysis, and it is important for you to be able to read them independently. So let's see the components of the forest plot and then how to read it. First, the forest plot will always have these two lines, one horizontal axis and one vertical axis. The vertical axis is called the null effect line, which means that this is the line that has no difference, or this is the point that shows no difference between the treatment group and the control group. So both the treatment and the control group should have no difference if the point estimate or the interval touches this line. Okay, so this line means that there is no difference between the group 1 and group 2. And the two sides of the line, I mean the right side and left side, will describe either the treatment group or the control group or vice versa. Okay, on the horizontal axis, we can see the measure of the risk, either the odds ratio or the relative risk, if it's 1, and if it's 0, if the null effect line is 0, then we describe the risk difference. Okay, so again, if the value of the null effect line is 0, it means that the measure that was used was risk difference. However, if the null effect line was 1, as you can see in this example, this means that the measure that was used is odds ratio or relative risk. Okay, then if you remember from the previous slide, I say that the red lines or the intervals describe the individual studies, and yes, this is true, because the box in the middle of the line is the point estimate, and the interval around this box is the interval estimate, and usually we use the 95% confidence interval. And the sizes of boxes and also the lengths of the lines can be different, as you can see. So the larger the box means the highest weight of the study. So the larger box or the larger size of the box mean that this study or this individual study or this individual clinical study has greater weight for the overall evidence of the systematic review or the meta-analysis. Okay, and of course the trivial studies or the least important studies will have smaller boxes. Okay, this is the size of the box and what does it mean. Also, the location of the box is important, because if the location of the box is on the right side, and this right side was the control side, it means that this study favored the control over the treatment. However, if the box was on the left side and the left side was denoting the treatment group, then it means that this particular study preferred the treatment over the control. Okay, so again, there are two features of each box: the location of the box and the size of the box. The size of the box refers to how much this particular study is important for the whole or the overall evidence from the systematic review. Then the location of the box, either to the left side or to the right side, means this is the side or the treatment group that this particular study favored. Okay, this is related to the box. Then the interval. If the interval is long, as you can see, it means that this study has low level of quality, because the more robust study will have shorter confidence interval, because this is the interval where the true effect size could be located. Okay, so this is the individual studies and the representation of it. Also, if you can see here, there are some intervals that are touching the null effect line and some intervals that are not touching the null effect line. So what is the difference between them? What is the difference between the first two studies and the third study? The third study, as you can see it here, does not touch the null effect line. However, the first two studies touch the null effect line. It means that the first two studies could have non-conclusive result because those studies are insignificant. This is how we call it. They are not significant. Why they are not significant? Why the results are not conclusive? Because the interval can be either on both sides, either in favor of the treatment or in favor of the control. That's why if the interval or if this horizontal line touches the null effect line, it means that the study is insignificant or inconclusive. However, if the interval or if the 95% confidence interval does not touch the null effect line, it means that this study is definitely in favor of the side that is in it. So if it's in the treatment side, it means that it's definitely say that this treatment is effective. If it's on the control side, it means that it's definitely for the control side. And this is the difference between the studies that touches the line and the studies that did not touch the line. The studies that touches the line are called not significant studies, and the studies that did not touch the line are called significant studies because you are sure that they are not favoring the other treatment. They are definitely in one side. Also, if you can see here, there are names and numbers. The name is the last name of the first author of the article, and the number is the year of publication of this article. Also, there are other numbers for each like study, which is, for example, in the first study, which is Gamsu 1989, there is 15 out of 131. What does it mean? It means that the treatment group had 131 patients, and 15 of them experienced the outcome, or let's say the clinical improvement. However, in the second group, which is a control group, out of 137 control patients who received the placebo, for example, 22 got experienced the outcome. Maybe it's a complication or it's clinical improvement. We don't know, but this is what it means. The second study had 36 patients in the treatment group. 12 of them experienced the outcome, and in the control group we had 41 patients, and 12 of them got the outcome. Okay, so this is the names and numbers that you see here. Also, what's also important about the force plots is the last thing that you see at the end, which is the diamond. So this black diamond is the point estimate of the whole studies from all these systematic review. So this is the average point that comes from all these previous individual points of each individual study, and this is the overall effect size. This is how we refer to it. So the overall effect size comes from estimation of all the individual studies. And as you can see also on the right side of each force plot, there is the measure of risk, which is the risk ratio or risk difference or odds ratio. And you will see the boundaries of it, which is the boundaries of the 95% confidence interval and the point estimate. Okay, so these are all the components of the force plot. And now let's look for the heterogeneity. So heterogeneity is a concept that describes how much the individual studies were either very similar or very unsimilar to each other. Because if they are similar to each other, this means that the evidence that we will get at the end will be more consistent, which is like good for how much we should be certain in this evidence. But if this evidence came from totally different studies, this might make us a little bit uncertain, but this doesn't mean also that this study is not good or this systematic review is not good, because you sometimes need some diversity in your study, because we need to have diverse population groups and diverse dosage of medications. So all these will make the studies that are included in systematic review more heterogeneous. And regardless if it's like supposedly homogeneous or heterogeneous based on the clinical questions that you are developing, you need to be able to read the heterogeneity amount. So heterogeneity is a concept that is described or is measured using what we call the I-squared statistic. So in this study, or in this particular systematic review and meta-analysis, the I-squared value was 38%. And please remember this. If it's between 0 to 50, it means that this study has low level of heterogeneity. If it's from above 50%, like 51 and above, in this case, this will be a high level of heterogeneity. Okay, so again, from 0 to 49, this is low level of heterogeneity. From 50 to 100, this is high level of heterogeneity. Okay, I would say there is no blessing or cursing in having high or low level of heterogeneity. However, most researchers or most scientists prefer low level of heterogeneity because this will make them more comfortable for the usage of evidence. But like statistically and methodologically speaking, there is no blessing or no cursing in high level of heterogeneity, for example. Okay, the students for evidence for best evidence is a good website for you to understand more about forest plots and evidence-based medicine in general if you are interested. And now I will move to the other part of utilizing evidence. So after you manage to read the forest plot and understood what the evidence tells you, you need to make a decision about this evidence, whether this evidence is like the thing that you should follow or not, which is the strength of recommendations that you will make based on the quality of this evidence. So the evidence could be of good quality or low quality, and also the recommendations that you will make for this evidence can be a strong or weak recommendation, because not all good evidence should be strongly recommended, and I will explain to you very soon why it shouldn't be automatically and strongly recommended automatically. The grade methodology is the methodology that is used to make this kind of discrimination or these decisions because it considers a variety of factors like the study design, the consistency between the studies, the directness of the evidence, the precision of the evidence, and publication bias, and others. So let's see how it works. First, the evidence itself needs to be rated. Either it's a good evidence or high quality evidence or low quality evidence or very low quality evidence. The first step is to think about the study design. If the studies that were involved in the systematic review were randomized trials or observational studies. If they are randomized trials, then in this case you will give high confidence in the study. But if it's observational studies, then you should give low confidence. This is a starting point. So it's either level 4 or level 2. Then you're going to ask further questions about the studies that were involved. And for each question that you can ask, you're going to either increase the confidence by 1 point or decrease it by 1 point based on the answers for the following questions. So for example, you're going to ask about the risk of bias of each individual studies or the overall individual studies. So this risk of bias, if it's high, then in this case you have to lower the confidence. If the studies that are included are not consistent, then you should also lower the confidence score by 1 point. If the studies have publication bias, or if the systematic review had publication bias, then in this case you have also to lower the confidence. However, the factors that can increase confidence, for example, the large effect. So if there is like huge difference between the treatment and the control group, for example, the risk ratio or the relative risk was 7 times or 8 times greater than the other group, then in this case this is large effect size, and this will increase our confidence in the level and the evidence. If there is dose response relationship, and in the next seminar we'll explain the dose response relationship in specific, so if you are not able to understand it now, don't worry. And okay, so for you just now you have to remember that these are the techniques that we use to rate the evidence. And after you rate the evidence, you can say that this evidence is high quality or low quality. But this is not enough to make the recommendation, because for making the recommendation, you need to think about other parameters. It's not only the quality of evidence, because the quality of evidence here, as you can see, is just the first element. It's just one element of the 4 elements of making the recommendation. So the recommendation can be either strong or weak based on the consideration for all these parameters together. So for example, if the evidence is of high quality, then the recommendation should likely be strong. But if the evidence is of low quality, then the recommendation should be weak. Okay? But then the balance between benefits and harms and burdens. So if you have new drug or new intervention, you should think about the clinical benefits of this drug. And if these benefits really outweigh the harms or the side effects of this medicine. And also, if they are complicated, this, I mean, for doctors or for nurses to apply it, then in this case, this will be a negative point. So if the benefits outweigh the harms and the burdens or the causes of the treatment, then in this case, this treatment will be more likely to be strongly recommended. Okay, but if the opposite, if the risk-benefit ratio is not like convincing, and if the like treatment is complicated to be applied by doctors, in this case the strength of recommendation will be lowered. It might not be strong, it may be weak at the end. Okay, then the patient's values and preferences, we need to respect them, because for some treatments there is heterogeneous level of public perceptions. There are values that are contradicting this treatment and not enabling people to accept it easily. And there are other treatments that are strongly rejected by the population, other treatments that are like not like rejected but not also welcomed easily. So there is some debates or some controversies about it. So if the treatment has these kind of controversies or this societal resistance, in this case the recommendation cannot be very strong, because you need not to enforce people to take something that they are not willing to take. You need to respect the values of your patients, as we said at the beginning. Also, the resources and costs that are involved. If the treatment has very high price, in this case you should avoid recommending it, because there could be alternatives that could have similar benefits or like not very different clinical benefits, and providing these cheaper more cost-effective alternatives would be better for your patients, because this means that more people will be able to access this treatment and more population members will be able to benefit from it. So you're not only willing to benefit the elite or the rich people who can access this treatment, but you try to benefit as much as possible of the population. That's why your recommendation need to be sensitive for the economic also questions about the treatment and the resources are needed for affording it. As I said, the quality of evidence can be either high quality or low quality, and also the strength of recommendation can be either strong or weak recommendation. Here I will leave this table for you to read it and study it on your own, because I'm sure that you will be able to understand it, because these are the conditions of when to use the evidence and when exactly to recommend it and how you can recommend it, whether you recommend it with a strong tone or with weak tone, and the evidence when you describe it, is it high quality or moderate or low quality evidence. Then after you decide about the evidence and using it, you need to remember that unfortunately today we have estimated 17 years of gap between the scientific evidence, the scientific medical evidence, and the patient's care. So the medicines that are developed today will be unfortunately commonly used by doctors and patients maybe in 10 years or even more. This is the reality of our world. Yes, there are a minority of doctors who are willing to help their patients with the highest standards of care, and those are usually the doctors that are most updated and most willing to apply evidence-based medicine in their life, like seriously. Also, the problems of applying evidence-based medicine are not all related to the doctor and their awareness. Sometimes the context where the doctors are operating cannot help them or cannot support them to apply evidence-based medicine. Maybe the hospital is not well equipped, or the system where they are working does not really well to support them financially for like bringing these technologies. So the questions that doctors need to ask themselves before applying any new evidence, for example, are the patients that are in these clinical trials similar to my patients in terms of gender, age, race, ethnicity, and others? If the treatment that is like recommended, is it available in your health system or not? What are the alternatives? And if these alternatives are less or more expensive, and if they are, let's say, less expensive, but then the clinical benefit is not that huge for this new medicines, and why you're gonna use it? Because it will not help most of the patients. It will help only minority that can afford it, and then this will increase the disabilities or the inequalities in health that we don't want to see anyway in our population. Also, the outcomes that are like looking for, if they are appropriate to your patients, like are these the outcomes that your patients are really expecting from the treatment or not? Then this will definitely come from conversation or direct talk with your patients. And then you shouldn't forget to evaluate the outcomes of implementing any new evidence in your clinical practice, because evaluation is like a sustainable process. It has to be done on a regular basis for all new changes, and this should inform your future decision and your future questions. I will not like repeat the things that I said already in the lecture about this step. And finally, I would like to share with you these resources because they are very important for you if you are interested in evidence-based medicine. These are external sources that you can revisit not only this year but also later on if you would like to learn more about EBM, because as I said, this is the future of medicine and this is the future medical style that you will all have to apply. Thank you for your attention and see you in the classroom.